Good day everyone, we are Group 2 from Opto 2-1. I'm Lian Ramos.
I'm Gierke Manait.
And I'm Edward Lucas.
And we are here to discuss to you a type of glycogen storage disease, the type 1 or commonly known as the von Gierke's disease. Included in this presentation are its types, pathophysiology, epidemiology, diagnosis, and treatment. Let's proceed.
Von Gierke's disease, also known as a glycogen storage disease type 1. It is the most common disease in which the body has the inability to break down glycogen. It is perceived as the glucose 6 phosphate deficiency in the liver, kidney, and intestinal mucosa. It was first described by von Gierke in 1929 and has an estimated incidence of 1 over 100,000 live births. It is an inherited disease that are usually diagnosed before the age of 1. Furthermore, GSD1 is treated with proper dietary management at times when therapies don't work, kidney or liver transplantation is needed. For more information, let's dive in deeper to the contents of this poster.
Glycogen storage diseases are a group of disorders in which stored glycogen cannot be metabolized into glucose to provide energy to the body in order to maintain steady blood glucose levels. Von Gierke's disease, also known as type 1 glycogen storage disease, is inherited as the autosomal recessive genetic disorder. Von Gierke first described the condition in 1929 when he reported excessive hepatic and renal glycogen in the autopsy reports of 2 children. Furthermore, it is distinguished by the accumulation of excessive glycogen and fat in the liver and kidneys, which can result in an enlarged liver and kidneys as well as growth retardation, resulting in short stature. Enzyme deficiencies prevent glycogen breakdown in affected organs, resulting in excess glycogen and fat accumulation in body tissues and low blood glucose levels. A lack of enzymes causes an imbalance or excessive accumulation of other metabolites, particularly lactates, uric acid, and fats such as lipids and triglycerides.
Thank you, Edward, for that wonderful introduction of the disease. Let's get to know more about it in terms of genetics, enzymes, and body parts involved. Hence, its pathophysiology. G6Pase is primarily found in the liver, kidney, and intestine. Its active site is located on the luminal side of the endoplasmic reticulum. Glucose 6-phosphate translocase transports glucose 6-phosphate from the cytoplasm to the ER lumen. The G6Pase or G6PT complex catalyzes the final step of glycogenolysis and gluconeogenesis for glucose production. A lack of either causes glycogen and fat accumulation in the liver, kidney, and intestinal mucosa. Glycogen storage disease type 1 or von Gierke's disease is an autosomal recessive genetics disorder. Recessive genetic disorders occur when a child inherits a non-functioning gene from both parents. So, if a person receives one working gene and one non-working gene for the disease, the person will be a carrier but will not show symptoms. Von Gierke's disease is linked to mutations in 2 genes. Mutations in the G6PC gene cause a lack of glucose 6-phosphatase enzyme, which accounts for approximately 80% of GSD1. This is known as glycogen storage disease type 1A. Mutations in the SLC37A4 gene cause a lack of the glucose 6-phosphatase translocase enzyme, which accounts for about 20% of GSD1. Glycogen storage disease type 1B is the name given to this type of GSD1. Both of these enzyme deficiencies cause excessive glycogen and fat storage in the body tissues. So, children with von Gierke's disease are usually diagnosed before the age of 1. A proper physical examination and detailed history points to the diagnosis. Some of the tests include blood glucose, blood pH, kidney function tests, complete blood count, serum, electrolytes, urine albumin, liver function tests, blood coagulation profile, cholesterol levels, and bone density measurement. Ultrasound imaging of the abdomen to investigate the enlarged liver is needed, and to assess also the kidney for complications. In females, ultrasound may reveal polycystic ovaries. So the definitive diagnosis of von Gierke's disease is by liver biopsy and assay of enzyme activity. Gene testing, a recently available test that can detect mutations, provides also a non-invasive technique for definitive diagnosis.
In line with this, it is important to remember that the condition is inherited as an autosomal recessive disorder. In fact, prevalence is unknown, and based on annual reports, incidence is about 1/100,000 births. Among the two types of von Gierke's disease, GSD type 1A is the more frequent type, representing about 80% of type 1 GSD patients. A great example of this case will be from the Ashkenazi Jewish people. The incidence of GSD1 in the overall population is 1/100,000, with GSD1A and 1B prevalent in the 80% and 20% respectively. Additionally, the Ashkenazi Jewish population has a 5 times greater prevalence compared to the rest of the population. Moreover, this condition affects males and females in equal numbers in any given population group. Since it is an inherited disease, the disorder, which occurs in only about 1 in 200,000 persons, first appears in childhood and carries a high mortality rate in the early years.
Since we are already aware of its incidence and its mortality rates, we must know its management or treatment. GSD1 is treated with a special diet to keep glucose levels normal, prevent hypoglycemia, and maximize growth and development. Small servings of carbohydrates must be consumed frequently throughout the day and night. To avoid deficiency, calcium, vitamin D, and iron supplements may be recommended to maintain the improved blood glucose levels. Uncooked cornstarch is fed on a regular basis. Allopurinol, a uric acid lowering drug, may be useful in controlling the symptoms of gout-like arthritis during the adolescent years. Medication may be prescribed to lower lipid levels as well as to prevent or treat kidney disease. Recurrent infection in GSD type 1B patients may be treated with human granuloclide colony-stimulating factor. With tumors can be treated with minor surgery or a procedure in which they are ablated using heat, and current kidney or liver transplantation are sometimes considered if other therapies are unsuccessful or where liver adenomas keep growing. Individuals with GSD1 should be monitored at least annually with kidney and liver ultrasounds and routine blood work specifically used for monitoring GSD patients. Genetic counseling is recommended for affected individuals and their families.
That's it for this presentation. Once again, we are Group 2 and this is von Gierke's disease. Thank you for listening and have a nice day.